Welcome to another episode of the PML podcast. This is a knowledge drop session. I love this. I just started doing this last week and I find it very valuable for my patients as well as my colleagues in the pain world and the spine surgery world as well as interventional radiology world. This is going to be just a brief understanding of the PML technique. Right there to my left, this is the ideal PML surgery. This is one of my patients that I did, and I framed it because it was one of the first patients that I did. And basically, the FDA approval is for two screws on both sides, but I found out that if you can put three screws on both sides, it's fantastic. It just gives it more stability. You don't have to worry that one screw is going to come loose. And if you aim towards the teardrop, which is what you see here, so you can see those screws are going in the anterior synovial joint, not in the posterior portion, because I've seen a couple of x-rays where people have screws going in this direction. If you go in this direction, you're going to catch some ligamentous portion of the SI joint. Ligamentous portion is not ideal, okay? So you want to catch as much bony anatomy as possible. So this is a ideal portion. The anterior half of the SI joint is synovial joint. The posterior half is ligamentous portion. So again, you want to make sure that you catch the anterior portion. You can see on both sides. Maybe this one is a little bit posterior in the ligamentous portion, but I have two solid screws in the anterior synovial joint. This is a perfect inlet view. You can see down through the pelvis. You can see that the anterior sacral line is they're all overlapping. You don't see two lines. If you see two lines, that means you're not at a perfect inlet. So when you do your surgeries, make sure you get a perfect inlet, which is this. PML is posterior medial to lateral. Posterior medial to lateral. The conventional technique is lateral to medial, and then the posterior oblique lateral is from posterior oblique lateral to medial. The downside of the posterior oblique lateral is that it goes through ligamentous, and you can only put two screws. And then the length of the screw is limited by the ventral sacrum, right? For PML can go as long as 110 millimeter screw. There's no other approach that allows you to put 110 millimeter screw. Now, I've never put in 110 millimeter screw, but definitely put a 110 millimeter screw if the patient has a large pelvis. These screws are typically 65 to 70 millimeter screws. Again, posterior medial to lateral. Posterior medial to lateral. If you find your screw in the posterior margin here, that means you're starting to superior. The starting point on the AP view is in the inferior 1/3 of the SI joint. You never want to start your SI screw PML in the anterior and the superior 1/3 or the middle 1/3. The ideal starting point is the inferior 1/3. I always tell people, just remember inferior 1/3 on the AP view, anterior half on the inlet view. Anterior half on the inlet view. This patient had almost 100% relief of the symptoms. SI joint dysfunction is mostly common in women. So I see guys that also have it. Predominantly guys that have had lumbar fusion to the pelvis or post-traumatic arthritis, but women typically just have it because of the way the pelvis works, the ligaments. We'll talk about ligaments at some point, but the posterior sacroiliac ligament is the strongest ligament in the SI joint. The weakest ligament is the anterior sacroiliac ligament. Anterior sacroiliac ligament lies here. Posterior sacroiliac ligament lies there, but it's long. It goes all the way from this superior portion of the sacroiliac joint all the way down to the inferior portion of the sacrum, and some of it actually has a short fiber that goes to the third and fourth portion of the segment of the sacrum, and then another portion that goes all the way down. So the posterior sacroiliac ligament is very strong. So anyway, back to PML. PML avoids the artery, the SGA artery. The SGA artery comes in from the lateral side. we're totally away from the SGA artery. Nobody wants to get a bleed. Okay, so you want to go in for posterior medius lateral, avoid the superior gluteal artery, as well as one incision. So you make one incision in the middle. You get two nice 6 screws across the SI joint. I'm sure you've seen the videos I posted on social media. Those are actual patients that had lumbar fusion prior, and then they developed SI joint dysfunction after that. Those patients did fantastic, 90% relief of pain after SI joint fusion. You can see my little mini-me here. A patient gave me this after an SI fusion. It's all like to the T, bald with the tie and even with the shoes. The shoes are me. So I keep this next to my PML. It stays nice and solid. The screws for the PML surgery are 3D printed screws. These are actual screws. So these screws are self-drilling, self-tapping screws. And the company that I use, they bring the screws in and they come in either in this package or I use several companies. I don't really have a preference, but it has to be 3D printed screw. And of course, the pelvis. If you're going to be a rep, if you're a rep, or surgeon, pain doctor, radiologist, interventional radiologist, interventional spine, you have to have your pelvis like in your bedroom so you can study it all the time. Because initially when I started doing MIS SI fusion, my pelvis was in my bedroom. So anytime I woke up in the morning or at night, I studied the pelvis. It's a very complex joint. It's the largest joint in the body. Now I can think of, I have dreams and nightmares about the pelvis, good or bad. But overall, it's been a fantastic, what do you call it, technique that I've invented. I give credit to SI Bone. They've been very helpful in the FDA approval with the federal government. We were able to get FDA approval, which is huge. Okay, so I've given talks at the #1 hospital in the world in orthopedic surgery, which is the Hospital for Special Surgery, again, Hospital for Special Surgery in New York. So we've done that. We've written a paper on PML in the Journal of Clinical Spine Surgery. So I think it's time for us to offer PML to the public, especially surgeons, interventional radiologists, interventional pain doctors. This is an easy surgery, easy procedure. We'll showcase it online. We'll showcase it one-on-one. I'll be teaching it live, one-on-one in Dallas. So feel free to shoot us an email and get on the wait list. But this is going to be a great journey. I want you to join us. Be prepared. This is hard work, but we'll get it done. All right. Godspeed.